everyone. It's great, a pleasure to have Dr. McGowan and also Dr. Devendra both here for our session. And so one of the cases that we had in our long COVID clinic at Queens is the one that you'll hear. So next slide. So this is a case of a 40-year-old female who has a history of GERD asthma, atopic dermatitis, and OSA, which she's intolerant to CPAP. She had uterine fibroids, status post hysterectomy when she was first introduced to our long COVID clinic. She also has anemia, eczema, and contact dermatitis. Primary prevalence or that of the long COVID, she has ME/CSF with episodes of post-exertional malaise, not uncommon for many of our long COVID patients. She has exhaustion, often associated with dizziness, coughing, and occasional clear to hazy sputum. She's able to work 4 to 5 days remotely with some improvements noted, but requires sometimes off days. Free so far in this month. She has episodes of crashing fatigue precipitated by prolonged work or allergies. She sleeps on average 6 to 7 hours per night. And her medications are with her montelukast. She was on a trial of ICS LABA for which she didn't have any improvements on symptoms. She's on propranolol for her probable autonomic symptoms, and then she's also used an expectorant for chest congestion. So next slide. And so her vitals are stable. You can see that pulse ox is 97%. She's not tachypnic or her lungs were clear. There were no crackles, and 6-minute walk test was abnormal. She's able to only walk about 900 feet, but she does have stable oxygenation. There's no desat. Echo was normal, PFTs was also normal, and then subsequent spirometry and PFTs were all normal in 2024. Chest X-ray showed no infiltrates, and on CT scan, she showed no interstitial lung disease. She had some trace pulmonary pleural effusion, and then there was just a benign hepatic lesion. Sleep study showed that she had a mild OSA, but intolerant of the CPAP, and EEG was normal in 2024. Next slide. And so the questions that we had for the team are, with the longstanding COVID features, she still continues with hydration and salt on propranolol 3 times a day, primarily because of her POTS. She started recently on Dupixent, and that actually helped a lot, both in terms of her skin condition, but also her respiratory symptoms also. And you can see the rest of what we currently have her on. The questions that we have for the providers are, is this her new normal, and will she ever get back to her baseline prior to COVID? Any suggestions on controlling her intermittent respiratory symptoms, in which she still has those coughing episodes? And are there any lifestyle modifications that you guys would suggest? And so with that, Dr. McGowan, we leave it to you.
Great. Thank you so much. Hello, everyone. I'm going to go ahead and get my screen shared here. And after all of these years of Zoom, still am not perfect at it. Can everyone see my slides okay?
Yes.
Wonderful. We did it correctly. Okay. Well, thank you, Dr. Chow, for that setup. And I think that case really perfectly maps onto what I want to talk about, and just many of the patients that we see at our clinic at UCSF. And so just by way of introduction, my name is Sammy McGowan. I'm a pulmonary critical care doctor at UCSF. And my primary exposure to COVID has been managing patients in the ICU, initially with severe COVID ARDS, and focusing on the recovery from critical illness. And as part of that work has been this growing recognition of our folks that have recovered from COVID but have not had critical illness. So I'll try briefly to bridge those two worlds. So starting with understanding the impact of critical illness on ICU survivors, talk about something called the post-intensive care syndrome, and then talk about the overlaps between PICS, post-intensive care syndrome, and long COVID, and then delve into the pulmonary complications in long COVID. And so, like I said, my experience with COVID really started in the pandemic, and my research interests start from exploring the eye in the ICU. That the ICU is a very intense place. Aside from the intensity of the illness that they experience, they are subjected to a lot of invasive monitoring and procedures. They are subjected to a physical isolation for infection control reasons and enable so that we can deliver them care, but also emotional isolation. On top of that, they grapple with uncertainty of their prognosis, grappling with life and death decisions and the uncertainty of whether or not they're going to get better. And if they do recover, what will that recovery look like? And so I wanted to illustrate an example of a patient that's maybe on the opposite end of the spectrum of what Dr. Chow had mentioned. So this is a patient that I saw in clinic last year, Miss H, who's a 44-year-old woman who did have a past medical history of childhood asthma, who developed COVID in the summer of 2020. She had a very severe experience with COVID that included hypoxemic respiratory failure. She was intubated multiple times, had prolonged periods on a ventilator, both for at least 7 days at a time. She was subjected to a lot of the stuff we do for folks that have ARDS. So she required very deep sedation, paralysis or neuromuscular blockade, proning, so ventilating her on her stomach, as well as dialysis. During this, she had multiple cardiac arrests that involved many difficult goals of care conversations, and she survived her initial bout of COVID ARDS, but then was readmitted many months later for complications related to that first admission. So she had a pneumothorax secondary to all of this fibrosis that she had. And so I'll just briefly try to illustrate this radiographically, understanding that folks are coming to this session with different levels of sort of medical knowledge. But this is her a couple days into her initial COVID infection. So these are slices of a lung CT, and you can see some mild areas of bilateral ground glass, but overall not an overwhelming amount of burden of her disease. And then a couple weeks later, when she has more severe symptoms and she's in the ICU, if my slide will work here. Oh. And then so this is a few days later. So you can see diffuse bilateral ground glass, consolidation, infection everywhere, lung injury everywhere, and emerging fibrosis. So long-term scarring of the lungs related to her COVID infection. And so it's no surprise that many years later, this severe event of lung injury is something that she's still struggling to recover from. So I saw her about a year ago now, maybe a year and a half, and she still had very severe anxiety. She's on multiple medications for uh, generalized anxiety. And she still has shortness of breath and cough. So prior to COVID, she was doing daily yoga and kickboxing. She had that childhood history of asthma, but did not really have a um, major issues with asthma. Now she is oxygen dependent. She cannot walk more than 1 block, and she's on a daily inhaler and as needed inhaler, and still trying to get weaned from chronic steroids. On top of that, she describes a morning fogginess that makes it hard for her to function, and her cognitive symptoms uh, get in the way each morning, as well as a chronic insomnia. And this collection of symptoms is something we see a lot in our ICU patients even before the pandemic. So we know that folks that survive critical illness have a hard time recovering. So 10% of patients that have had prolonged ventilation, even as much as only 4 or 5, 6 days, less than 10% of them are alive and fully independent after 1 year. Half of patients that have ARDS, like my patient Miss H, half of them have not returned to work after a year. Um, Rates of depression, anxiety, and PTSD in the months and years following discharge is very high. And then we see that patients can develop either worsening cognitive impairment or new cognitive impairment after they've experienced critical illness. This collection of symptoms that describe worsening physical function, mental health function, and cognitive function, we call the post-intensive care syndrome. And I'm spending a lot of time talking about this ICU syndrome, post-intensive care syndrome, because what we have found is that while many long COVID patients, so many of our, so let me back up. So our first long COVID patients that we saw at UCSF were our post-ICU patients. And so they fit into this framework of physical, mental health, and cognitive impairments. And what we have found as the pandemic has waned in certain ways is that while many patients may not have been hospitalized for COVID, they still, in some ways, fit into this framework. And that informs our management approach for the management of dyspnea in long COVID. So I'll just briefly talk about our clinic model and then a little bit about sort of how we approach a patient that has shortness of breath and a history of COVID. So our clinic is called the Optimal Clinic, and that stands for post-COVID, post-ICU, multidisciplinary clinic. So we see folks that are survivors from the ICU that didn't have COVID, survivors of the ICU that did have COVID, and then folks that had COVID but may not have been hospitalized at all. And we have a multidisciplinary team. And depending on their needs, they might see different members of our team. Our core members are myself. So I am pulmonary and critical care trained. So I tend to see more of the folks with respiratory issues or ICU recovery. And then I have an internal medicine counterpart. And then we also have an integrative health center. And aside from our core team members, we have very close partnerships with physical and occupational therapy that help us with our physical functioning symptoms, cognitive function symptoms, as well as a host of other um, subspecialists that might need to be consulted. In terms of my management principles, I start with identifying and treating reversible causes of the symptoms. And so, something that I'm sure you have heard in other presentations, but really, I think the gold standard of long COVID management is thinking about long COVID as a diagnosis of exclusion, which means that for every symptom, for every complaint that you're presented with, thinking systematically and robustly about the alternative explanations for those symptoms and potentially treating them. Embedded within my clinic is also a pharmacist. I have an amazing ICU pharmacist that sees my patients, which is, I know, like such an amazing luxury that I have. And she's very helpful because polypharmacy is a huge problem for many of our post-ICU patients and many of our long COVID patients. And so we are commonly seeing folks that have been put on lots of different medications that have drug-to-drug interactions, or the doses have been done in an odd way, or maybe they were put on something, many years ago that was meant to be tapered off, and there's adjustments that we can make. And particularly our folks that survived the ICU, a lot of changes to their medications happened while they were in the hospital, and understanding what those changes were and why, and if, the Seroquel that somebody added one time while they were in the ICU for one night, whether that really needs to be a long-term medication. The other main thing that I very commonly am evaluating is folks that are on steroids. I find that particularly folks that have been in the ICU, but even non-ICU long COVID patients, they have very frequently been started on steroids. And unless I have an alternative explanation for why they need to be on prednisone long term, I'm almost always trying to come up with a plan to wean them off of prednisone as soon as possible because the risk of long-term prednisone use far outweighs the benefit that they might see. As I will get into, managing reactive airway disease is probably the most common thing that I see in our clinic. And then I, of course, will lean on my internal medicine colleagues. While I am internal medicine trained, I love my internal medicine training. I am frequently working with my internist colleague, Dr. Wong, who helps me with the non-pulmonary parts of the complaint and working together to take care of folks. And then to me, while I obviously believe strongly in the work that I do, I think what makes our clinic really tick and what our patients seem to really love is our rehab programs. And so we not only do we have sort of traditional pulmonary rehab, which is a program that's offered for folks with chronic severe lung disease, we also have dedicated physical therapists and occupational therapists that have specific experience working with patients with long COVID. And I meet regularly with them. We'll do huddles as a team and talk about patients together. And I find that that multidisciplinary approach is what really helps us help patients. So, what do I do working up a patient with shortness of breath and long COVID? It's really not that dissimilar from any patient that comes to me with shortness of breath. So, sort of simple lab work that's evaluating for potentially alternative causes of their shortness of breath. So, CBC with, I do always get a CBC with differential and an IgE to evaluate for T2 inflammation in the event that they have asthma. CMP, so looking at their liver function, looking at their kidney function, their thyroid, their electrolytes, B12, folate, iron studies. The I'll just say it again. The number of times that I have diagnosed non-long COVID related causes of dyspnea is very high. So just because they come to my clinic doesn't mean I turn off the rest of my sort of medical expertise hats. We've diagnosed blood loss anemia. We've diagnosed cirrhosis. We've diagnosed thyroid problems in our clinic. So not just assuming that all of the workup has been done before, but double checking that all of the basic labs have been done is an important part of our workup. For me, labs that I find to be less helpful are sort of non-specific inflammatory markers like ESR and CRP or a CK, or even a D-dimer, unless I have a specific concern or suspicion for a rheumatologic condition or muscle weakness related to interstitial lung disease or heart failure. I don't typically get these labs because I don't find that they really change my management. And then aside from that, most of my patients are getting pulmonary function tests. At the very least, they're getting spirometry and a DLCO and a 6-minute walk test. And then if they have a totally normal chest CT, normal pulmonary function tests, sorry, if they have a normal chest X-ray and normal function tests and no comorbidities that have me concerned, I don't always get a CT chest, but frequently in the workup for dyspnea, a CT is part of the evaluation and then a TTE as well. There we go. If I had sort of one thing that I would take away from taking care of lots of long COVID patients, it's this relationship between long COVID and reactive airway disease. I would say by far that's the most common thing that I see and am able to help patients with sort of proactively, at least as it relates to medication therapy. So this is an important study that was done during the pandemic in a large prospective cohort looking at folks with a pre-existing diagnosis of asthma, not necessarily saying that they had active asthma symptoms or being managed, but they at least had some prior history of asthma at some point. And they found that in folks that have long COVID, they have a much higher inhaler use and a much harder time controlling their asthma after they contracted COVID. And this is really the sort of bedrock of my management approach is having a very high index of suspicion that folks might have reactive airway disease as part of the syndrome that's leading to their shortness of breath. And then if there was one slide that I recommend sort of thinking about or even screenshotting, it would be this slide. And it's not mine, it's from my counterpart, Dr. Schwab at UCLA. But this is really the framework and differential that I think about in terms of my patients that have long COVID that have persistent symptoms. What are the different things that I am thinking about? So, as I said, sort of number one on my list always is I have a high index of suspicion for reactive airway disease. Even if my testing is negative, you may or may not know our lung function tests, our lab work, they're not perfect because asthma or reactive airway disease is a variable process. It's not always going to get picked up on testing. So I always want to tr at least try folks on a therapy and a really good kind of robust trial of management of reactive airway disease before I cross this one off. As I said, deconditioning and physical therapy work is a huge part of what we do in our clinic. And so almost all of my patients with shortness of breath are doing some kind of deconditioning. Some folks will develop organizing pneumonia from getting COVID. That doesn't necessarily have to be a hospitalization for COVID. And so a lot of my folks are getting CT scans, and that is really the only situation in which I'm considering steroids is if I think that they have an organizing pneumonia. But the vast majority of cases, I'm reviewing their CTs. Maybe they did have an organizing pneumonia at some point, but I am almost always de-escalating steroids. Um, but that's certainly part of the differential. As I said, my patient with severe ARDS had post-ARDS fibrosis, and so that's the main thing I was managing her for. But unfortunately, there's no proactive treatments for that fibrosis. It's mostly supportive care. And again, de-escalating medication, so not giving steroids for fibrosis. And then very rarely pulmonary vascular disease. And then we also think about other sorts of comorbidities that can worsen symptoms. So acid reflux, neuromuscular weakness, vocal cord dysfunction. This often involves lots of evaluations from other experts. Some resources that I use a lot. This is a resource from Johns Hopkins that I will provide to patients in thinking about, what do we do in the patient, for example, for Dr. Chow, that we really did a very robust workup, didn't come up with any sort of comorbidity or problem that was identified that to be reversible. How do we get somebody back and moving and living with their dyspnea and hopefully seeing some improvement? And I would say, our physical therapists are really good at working with folks um, that need this progressive or graded approach to increasing their functional capacity. I think what I see very commonly is that folks, maybe they saw their primary care doctor, they went to a traditional physical therapy system that they were just sort of kind of thrown onto the treadmill and said, go as fast as you can, push harder. And being sort of asked to go from 0 to 60 really exacerbated their symptoms and they never wanted to come back. And what we find is that with our physical therapists that have um, a lot of experience with long COVID patients. They're very good at getting folks adapted to one level of activity, increasing in a little bit, getting them adapted to that level, increasing a little bit, adapt, increase, and over time, seeing marginal improvement. So what I tell folks is, you know, if I can't promise that I'm going to have you run in a marathon anytime soon, but if you work with us, and you're patient and you work at it slowly, you'll definitely see improvement, and that's been our experience. Just briefly, so our data for our clinic is still ongoing. This is our early data from early in the pandemic. So focusing on um, hospitalized patients with COVID and sort of like survivorship from COVID hospitalization, we do find that our clinic reduces ED visits, but the impact that our clinic has had on long COVID dyspnea that is not related to hospitalization, I don't have that data yet, but hope to share it soon. Okay, so just to conclude, our long COVID patients with dyspnea predominant symptoms, they often overlap with this post-intensive care syndrome. So even my patients with dyspnea, I always think, what is their physical function? What is their mental health? And what are their cognitive symptoms? Because those three are very connected and relate to their shortness of breath. Two, reactive airway disease. Number one, number two, number three, most common reasons why folks will have shortness of breath after COVID. So I have a very, very high index of suspicion. Number three, all that long hauls is not COVID. So part of my dyspnea evaluation is to make sure to rule out any other causes of dyspnea. And then finally, developing a symptom-driven management approach and our pulmonary rehab and physical therapy. Those are our mainstays of treatment. So with that, I thank you so much for your time, and I will pass the talk over to Dr. Devendra. So thank you so much.
Thank you, Dr. McGowan. And I think that sets up what we have experienced here in Hawaii. So, Melissa, do you have my slides up? So, I wanted to just discuss long COVID with pulmonary symptoms in Hawaii. And next line, slide. So a couple of the learning objectives is understand the COVID-19 epidemic in Hawaii, and then understand pulmonary symptoms and complications associated with long COVID. Next slide. So, oh, can you go back one? Oh, yeah. Perfect. So, oh,
sorry, I don't know what, it just keeps popping forward.
so
Is there a timer built in to it?
Oh, okay.
Hopefully
Yeah.
not.
Yeah,
Yeah.
maybe
There is a
maybe
timer.
uncouple it. Don't do it on presenter mode. Do it on the other mode.
or I think I have it up. I could share my screen. I wonder if that'll be easier.
Yeah, that'd probably be easier.
Okay, let me do that.
Thanks, Dr. Devendra.
I think I've got it.
Do you see my screen?
Or here.
Yes, I see your screen.
Okay. So just to really go over, I'm having the same problems.
I think it's a timer. I think maybe just do it just uncouple it from presenter mode, maybe.
Yeah, I'm going to uncouple it. Okay, so this is what we saw during the COVID-19 pandemic in Hawaii. If you looked at the x-axis is the time and the percentage of patients hospitalized. And
Gehan, can you right now we're only on the pulmonary long COVID slide. Can you reshare? I think we're not seeing what you're seeing.
Oh, I see. Let me try. Do you see that?
No change so far. Melissa, do you
Yes.
happen to have maybe you could switch back to him?
Yeah.
Yeah, maybe you could switch back
Okay.
and then just do it not presenter mode. Yep. Okay, and just go back to wherever
Where the
Slide 4.
slide 4.
Thank you.
So this is the what we saw of the COVID pandemic in Hawaii based on ethnicity. And early on in the COVID pandemic, we saw a huge amount of patients of Pacific Islander descent. And we also saw a lot of Filipino patients who came into the ICU, and there was a huge population of deaths. At one point, Pacific Islander patients, they are only about 4% of the population of Hawaii, but they accounted for upwards of 30% of all deaths earlier on in the pandemic. So there was definitely a differences between ethnicities. Next slide. If we looked at the hospital fatality rate based on race and ethnicity, we found out that there was differences between Caucasian patients as well as from our Chinese, Filipino, Hawaiian, Japanese, and Pacific Islander patients. Next line. The reason I want to show that is this really talks about how many patients that we have seen that are of different ethnicities, and that we'd like to see if we can capture that in the long COVID space. So to give a definition of long COVID, and this is the National Academy's definition, is long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing, remitting, or progressive disease state that affects one or more organ systems. And really keeping long COVID, long haul COVID, chronic COVID, post-acute sequelae of SARS-CoV-2, those are all similar definitions. Next slide. So pulmonary long COVID, and the definition that I'd like to go back to is prolonged pulmonary symptoms, including dyspnea, cough, chest discomfort lasting more than 1 month after resolution of the initial infection. And that's what I used for our long COVID study, knowing that most of these patients had symptoms for more than 3 months. Next line. So what are the mechanisms of development of long COVID? And I think we have several mechanisms: pulmonary fibrosis, changes in repair, metabolic changes, microvascular changes, chronic inflammatory change, or mitochondrial dysfunction. Next slide. So when we look at the natural history, and this was a study done by University of Alabama, looked at patients with long COVID in their long COVID clinic, they found out that there were distinct groups of individuals: patients who had long COVID, who had diffusion impairment on their PFTs without restriction, and those with different degrees of diffusion impaired restriction, either mild, moderate, or severe. And plotting it over time, that there was really not that much change in the people who had diffusion impaired restriction. Only a few people, and in this group, only about 5 patients were able to really convert back to a normal physiology. Next line. So we undertook a study looking at the pulmonary complications of long COVID in Hawaii, and we wanted to investigate the differences in blood, cellular, and immunologic profiles amongst 3 groups. The first group is patients with long COVID and pulmonary symptoms, participants who recovered from SARS-CoV-2 infection without any pulmonary symptoms, and then controls without any are those who did not have get infected with SARS-CoV-2. Next slide. In our group, we found that 9 patients had obstructive disease, 1 with resolved obstruction and 1 who developed obstruction after 12 months. And this goes along with Dr. McGowan's findings of having a lot of patients having obstructive disease. Next slide. In our cohort, we had 24 patients who had restrictive disease. Mild, 19 patients, moderate 4, severe 1 patients, and diffusion abnormalities were found in 7 patients. Next slide. When we compare it to the University of Alabama cohort, found out that those individuals with severe restriction with a diffusion defect, they saw in about 10% of patients, we saw in about 4% of patients. Those with moderate restriction and diffusion defect, University of Alabama saw 12%, and we saw about roughly 12%. Those with mild restriction with diffusion defect was in about 3%, and we found in our cohort 4%. And no restriction but diffusion defect, they found in 1.5%, and we found in about 12% of our patients. Next slide. However, the majority of patients that we saw in our pulmonary long COVID, who with pulmonary long COVID, don't have PFT changes. And the reason is unclear, and it may be due to non-pulmonary reasons. Next slide. So we're trying to look for future directions where correlate the pulmonary function data with health-related quality of life assessments, looking at EQ-5D-5L and looking at St. George Respiratory Quotient, and also looking at longitudinal assessment of PFTs. Next slide. So in conclusion, there is a development of restrictive lung disease with long COVID. The majority of patients have pulmonary long COVID symptoms, but normal PFTs, and really need to do more research to elucidate why this is this situation. Next slide. That's our funding source, and I want to say thank you. And just to put it in context of the patient that Dr. Chow had presented, is that we see a lot of patients just like that Dr. Chow's patient. Really, workup has been thorough. We really can't really find much defects. And with the patient that Dr. Chow, the only other thing that I would suggest is that we look at other non-pulmonary causes. So although it is a pulmonary cause, one thing that I do look at these patients is dysfunctional breathing. So there's the Brompton dysfunctional breathing assessment tool is what I personally use to see if there is more abdominal related breathing versus a mix, thoracic and abdominal breathing versus just thoracic breathing. So dysfunctional breathing is, we do see that quite frequently. And if you look at Sally Singh's work in the UK, she does see a lot of dysfunctional breathing. The other thing, a point that I want to bring up is that we also need to think about in this patient, I would also consider using a CPET in this patient to see if there are other defects, mostly peripheral oxygen utilization, mitochondrial dysfunction. Does this patient develop a lactic acidosis with exercise? And so those are some of the concepts that I would start looking at. And I think we also need to think that pulmonary, long COVID with pulmonary symptoms is really heterogeneous. You have the group that Sammy brought up, which they've been through hell and back through the ICU, and they have post-intensive care syndrome. And then they have very bad fibrotic lung disease at the end. And then we have the other side who have very little pulmonary, their PFTs are normal, their CT looks normal. Uh, some have gone through CPETs, and those are also normal. I've had also individuals with CPETs, their lung functions, their CT was normal. They undergo CPET, and they have a profound lactic acidosis that develops. And I think we're looking at really a lot of heterogeneous population, and that we have to really just try to hone in and find out what is the real reason that these patients are having what they're having. And Sammy, I want to open that up to you with your experience in your COVID clinic. The incidence of non-pulmonary causes of their dyspnea.
Yeah, I think that's a really good segue, and I think teasing out what is pulmonary and what is non-pulmonary is really tricky. I think especially with our folks that have the like CE it's like ME/CFS chronic fatigue phenotype, the post-exertional malaise, they will describe those symptoms as dyspnea, as shortness of breath. And so it can be tricky to tease that out. To answer, so Dr. Chow mentioned my question about reactive airway disease, and my general approach is to have a pretty robust empiric trial of inhaler therapy. So most patients that I see will have tried an inhaler, and I won't just kind of give up on whether an inhaler will be effective immediately. So if they've tried something like Advair or Wixela, I usually try to get them onto a formoterol containing inhaler where they can do smart therapy. So they can do single maintenance and reliever therapy and do very intense like inhaler teaching and make sure they're using it appropriately, encouraging them to use it before exercise, and really seeing if they can get the most out of the inhaler that they are prescribed. And I do find that like a lot of my patients, if they do like their albuterol, they're nervous to use their albuterol, and sort of coaching them on how to use it well. I do find that they get improvement in their symptoms, even if they've, quote, tried Advair and it didn't work. So that's a sort of main tenet to how I manage folks, is just having a really, really high suspicion, even if it seems like all of the testing is negative, because reactive airway disease can often have negative testing. I still don't necessarily believe that it's non-pulmonary until I've sort of personally done a really robust trial of inhalers. Um, and then to the question about uh yeah, patients being pushed too quickly in terms of recovery, a lot of that is just really coaching folks and setting expectations that we've done this robust workup, and we, while we haven't found a sort of physiologic correlate that matches one of our tests, the tests that we use in common clinical practice, they only get us a subset of slice of what's really going on in someone physiologically. So that does not mean that the symptoms are not real. I don't. So my relationship with CPET is that I find that it can be helpful sometimes, but I often find that it it will give me back a lot of data that I don't necessarily know what to do with. And so for me, the CPET I find most useful when I have a patient that has maybe multiple comorbidities, like they have a little bit of mild aortic stenosis and they have like a decreased DLCO on their PFTs, but normal spirometry, and they have multiple potential culprits. And I'm trying to figure out which one it is. Like maybe it would putting a new valve in this person actually help their symptoms versus focusing on their COPD versus something else. Um, and so I don't routinely, but I agree that it is part of the workup, but it's a very labor intensive thing. And for folks that are rural, um, I don't try to push it too much. Um, and yeah, so I guess that's my approach. I see some other comments in the chat, so I will stop talking.
Yeah. So just to kind of summarize, so you're actually just you're looking at the patient more, and you're actually pushing for reactive airway disease and trying to get a good adequate treatment and pulmonary rehab into the patient. Is that like your general approach to try to not give up, so to speak, and give them adequate for example, my patient, which she's not on an inhaler, so trying to get her back onto the inhaler and seeing and making sure that she does use the inhaler for an extended period of time to see some major improvement, and try to give it prior to exercise.
Yeah, and because I have a lot of patients that come to me and they say, look, I had asthma as a kid. I've never had asthma as an adult. I don't have asthma, but yet they had this bad COVID. And I see this all the time where folks did not have significant asthma symptoms. And it's 6 months after a COVID infection, and they're still coughing and they're still short of breath. And they respond very well to inhalers if they're used sort of, robustly and correctly.
That Dr. Lipa Kozayola mentioned, for me personally, to switch to Bosentan promotal eliminated the need for Gehan, albuterol, and Atrovent in sewer bursts. PFT showed mild obstructive pattern, and I don't know if you want to. I needed a change to avoid PL steroids.
Yeah, I was just thanks so much. This is really helpful as a family physician, but also as somebody who has long suspected my lung function worsened significantly after 3 bouts of mild COVID. So, but yeah, childhood asthma, pretty significant. Went away for college, no inhalers, developed allergies to every tree and grass in Northern California. Came home, medical school, stress of all that, needed to go back on my inhalers, right? Was pretty decently controlled and then just declined. So Singular was wonderful. And, put it on my patients all the time, especially since I'm atopic and hyper IgE, makes sense. But after the third bout, I like, something's definitely wrong. So yeah, the switch to formoterol was wonderful. And with my patients, I have had so many patients post-COVID that just like you said, Dr. McGowan, I don't have asthma. I've never smoked, blah, blah, and I just explained what reactive airway disease is and inflammation and long term, and you got to stick it out. And, we have our pharmacist in the clinic explain, we have the pharmacist at Longs explain, we put YouTube video, like all of these things to just really, really make sure, look at the insurance, which spacer device is covered, et cetera, because there's so many times people give up because they're actually completely using the inhaler incorrectly, and if we don't do that, then we go down this really long road of echoes and all of these other things, which in hindsight, it was just really poorly controlled, reactive airway disease. So, but I appreciate your comments on CPET. And so my question to Dr. Chow is it covered by insurance, and who does it? Because it's obviously very, very, very specialized testing. And, most even average pulmonary function labs wouldn't have the VO2 equipment.
I think Gehan's the best person.
So
Okay,
yeah,
Gehan, yeah.
so actually, at Queens, our director, Dr. Gilbert, is the director of the Pulmonary Function Lab, and he is also the one who reads all the CPETs. So we do, and I have not had any difficulties in getting a CPET ordered, and actually being able to get it approved. So I think it's covered by most insurers in Hawaii, but you just have to go through the process. Have you done this? Have you looked at other options of evaluating the patient's lung functions and finding out has everything been done? Oh, Dr. McGowan, I did have a question with those individuals who do have persistent their IgE is elevated and they do have persistent asthmatic symptoms after COVID. Have you used any biologics in these groups of individuals? And what's your experience with the use of these biologics in this post-COVID group?
Yeah, that's a great question. I make an eosinophil count and an IgE part of my standard evaluation because my hope is that they will respond as well as my other asthma patients do. I mean, I'm sure as those of you that take care of folks with asthma have experienced, like these biologics are incredibly effective. They are such a game changer. And so I am always looking to see if folks will qualify. And I do see that folks, even within a long COVID framework, if they've got clear reactive airway disease that's persistent despite maximal inhaler therapy or multiple bouts of prednisone, I'm putting them on, and I see the same results with my long COVID patients as I do with other patients. I think that the most common question I get with all of this reactive airway stuff and this diagnosis of asthma, do I have asthma? Are you saying that I have asthma now? Um, and that's one that's hard to answer, right? COVID is still so new, and it's hard for me to project. Are you like an asthma patient that's going to be on Dupixent now for the rest of your life? I don't know the answer to that. My hope and suspicion is that it's not the case, that we'll be able to de-escalate them. But I'm curious what your local experience is, but we're definitely we're definitely using Dupixent and Xolair, and I think the one that's going to be interesting for us for long COVID is Tespire, um, which is new. It does not require a eosinophil count, and so that lack of a biological correlate on lab work, but very persistent symptoms. I think that's going to be a tricky one. I don't know the answer to that yet. I have one patient that has just started Tespire that has long COVID, but it's too early yet to see if that's been successful.
I'd be interested because we do see I've been looking for elevated eosinophil counts in these patients and trying to figure out, do they have an asthma component, and really wanting to use Tezspire. In fact, I don't have enough experience using Tezspire in this group, so I'm curious to see what your experience is and if that would be another way that we can look to help these patients. Another thing that I wanted to comment on is there's a lot of patients who have not only the shortness of breath and pulmonary symptoms, but they also have neurocognitive. And that I do have a couple of patients who, with the treatment of their neurocognitive component, their respiratory component seems to improve. And I think that's more anecdotal, but what's your thoughts on that, Dr. McGowan? Have you seen that same issue? Those who have neurocognitive issues, they're treated with guanfacine, NAC, uh, and a combination, and see how that has helped their respiratory symptoms.
Yeah, I think anecdotally for myself as well, I've seen something similar. It's why for me, the PICS framework still is so relevant. And so addressing the global psychosocial needs of the patient and their cognitive components and their mental health components and their physical components, and sort of tackling that all at once together, I find globally helps patients. And at a certain point, teasing out like what is quote unquote pure respiratory cause of your shortness of breath versus something that's alternative matters a little bit less to the patient, like if they're feeling better. But I definitely agree. I've had a similar experiences where attending to some of these non-pulmonary symptoms helps their pulmonary symptoms.
And also, just going back to a global sense, I also go back to, are you exercising? Are you staying active? I still recommend 150 to 200 minutes of exercise for these patients. They don't need to run a marathon. They need to be progressive, as you stated. And then the other thing is diet. Uh, are they eating a good, healthy diet? Are they avoiding processed foods? I fully believe in the lung gut hypothesis that really does help helps these patients. And I wanted to see what you think of that as well.
Yeah, I think that there's definitely a connection. My counterpart in our integrative health practice is Dr. Carla Kwan, who does group visits for our long COVID patients, focusing on these mind-body connection, focusing on diet, is sort of anti-inflammatory nutrition and all that. And I find that it works. I mean, I think it depends on the patient. There are some patients for whom I think that approach works really well, and other patients that they just don't connect to it in the same way. But I totally agree that that is a part of the, yeah, multidisciplinary, multi sort of holistic approach to managing these patients, which is what I find so rewarding, right? Like it's not just plugging into this biomedical model where we're going to find the right thing that we can prescribe, but sort of taking together the whole person, their whole lived experience, and how we can improve their lives globally. So, yeah.
And there was a comment about air quality. Do you guys, do you do air purifiers or air conditionings, or do you notice any difference between uh, rural and urban dwellers, or?
Certainly. So as a pulmonary doctor, a part of my routine history taking, I didn't go into too much detail about that, but I am, and part of sort of reactive airway disease management is assessing for triggers and environmental exposures. And so in Northern California, we unfortunately have an increasing wildfire problem. And so my folks north of San Francisco, we have a big fire just east of Santa Rosa right now, and absolutely air quality has a huge impact on health. And so I'm definitely recommending folks get HEPA filters for their house if they have any kind of respiratory symptoms, and just doing a detailed history of helping folks think about things that could impact their breathing that they might not realize, like mold, water damage in their house. Do they have any birds? That's, my favorite question. As a pulmonologist, I got to ask every patient if they've got birds in their house, or other, steam. Do they use a steam sauna regularly? Do they use an indoor hot tub? There's so many kinds of environmental exposures that folks might not clock as impacting their breathing that could. So, yeah, I could do another whole 30 minutes on that topic.
All right. Well, I think we're at the end of our time. Thank you to our presenters, Dr. McGowan and Dr. Devendra, and thank you, Dr. Chow. And for everybody else, thank you for joining us. Our next session is on September 9th, and the topic that day will be post-exertional malaise in long COVID.